we mentioned that hemoglobin is a key carrier of oxygen, and this is the structure of hemoglobin. We have the four globin chains, which are the protein components. The globins can be two alpha chains, as in both fetal and adult hemoglobin, and the two beta chains in hemoglobin A. If you have two gamma chains, it becomes hemoglobin, fetal hemoglobin, and two delta chains makes hemoglobin A2. So different abnormalities of hemoglobin like sickle cell and so on alter the chemical composition of the globin chains, and in thalassemias we have less of the particular chains according to whether it is alpha thalassemia or beta thalassemia. So this is about hemoglobin. The main oxygen carrying component is the iron containing heme in the hemoglobin, and there are structural changes which happen in the hemoglobin which allow appropriate release of oxygen to the tissues and uptake depending on what is happening. So coming on to the uptake and release, we have the very important concept of the oxyhemoglobin dissociation curve. All of us are familiar with this. Just a quick overview of what it is so we can understand better. So we have the partial pressure of oxygen in millimeter mercury on the x-axis. We have the oxygen saturation of the hemoglobin in percentage on the y-axis. And obviously it's a sinusoidal or S-shaped curve. And the normal is in dark line, that's adult hemoglobin based. We have a shift to left, which is often the situation in the newborn period because of the high hemoglobin F that we have, and even in that you may have further shift to left or further shift to right depending on the factors we will discuss next. A shift to right may happen as well in certain situations as we will discuss. So when we say shift to left or shift to right, what we basically mean is that the shift to left will make the hemoglobin bind the oxygen more strongly. So for a given available hemoglobin oxygen level, the hemoglobin is more saturated. So suppose we have a hemoglobin, a partial pressure of oxygen of 60 with the shift to right, your saturation will be around 80, while with the shift to left, your saturation will go as high as 90. So this indicates that when you have a transfusion or multiple transfusions in a newborn, the fetal hemoglobin is partly replaced by adult hemoglobin, which shifts it to the right. So what you have as a 95% saturation on day one may actually be 90% after some transfusions at the same PaO2 level. So that is one of the things we should remember, that focus on saturation range is important, but the exact number within that range is okay, and we can start accepting slightly lower saturations as a transfusions, number of transfusions that the baby gets is more, and we will discuss that later as well. So shift to left is usually seen in newborns. As we said, there is more avid binding and relatively tighter release. This can happen with increased HbF, a lower level of 2,3 to DPG, and we can have hypothermia, alkalosis, hypocarbia, all shifting to the left. So even in older kids and adults, this can happen if these changes happen. And the level of 2,3 DPG, obviously, when you give transfused blood, the age of the blood has an importance in terms of the 2,3 DPG content, depending on what stabilizers we use for the bloods as well. So fresh blood usually has more 2,3 DPG, and as the age of the blood increases, 2,3 DPG keeps dropping, and that's one of the reasons we have the additional components added to the packed cells to maintain the 2,3 DPG function. And we also have a shelf life for the blood for mainly the same reason. After some time, it doesn't release the oxygen in the tissues well. So if the baby is really sick, go for a fresher bag as far as you can. And shift to right, where there is easier release to the tissue, happens with acidosis, hypercarbia, hyperthermia, reduced proportion of fetal hemoglobin, or increased 2,3 DPG. I hope this concept is clear. It's very important to understand this.